Right, okay, everybody. So this week's teacher topic is on organ donation, and really it's going to be aimed particularly at the sort of intensive care registrar and an anaesthetic registrar that's going to be sort of covering out of hours ICU. So I'm going to be doing sort of a 20-minute talk on organ donation side of things. Then you've got Liz Warrington, one of our specialist nurses in organ donation, that's going to be giving us about another 20 minutes to talk from the specialist nurse sort of perspective side of things in terms of the organ donation. We'll have questions at the end, and then we'll have a journal paper again around organ donation presented by Heather. So I will start sharing. Hopefully you should be able to see and hear this. If there are any problems, please let me know. Hello everyone. So I'm going to talk about 20 minutes, talk about organ donation, a bit of a brief update in the middle where doctors come in intensive care. We'll talk about why we need organ donation, and also why we need to catch every opportunity we can to facilitate organ donation, and why that's good for patients waiting for organ. I'll talk a little bit about who to refer, and brain injury and prognostication comes into that bit. Hopefully I'm going to make the whole area a little bit simpler. So first of all, why do you care? Now, as the ICU doctor, you're often the person called down to the ED or to the ward, to the patient with a sudden loss of consciousness. And really from the beginning, this is where things start to get confusing and a little bit complicated, because whilst it's really important that we think about organ donation for every patient that can donate, that is in a position to donate, it's really important that we don't jump the gun. We don't start talking about organ donation or even really thinking about organ donation until the time's right, and that's when the patient's approaching palliation. So let me go through that a bit more detail. The problem with organ donation is that people think about it too much at the wrong time, and I think not enough at the right time. This is a process map for a patient's journey. The problem is you don't know who's going to improve and who's not. There's a general rule: you should be admitting a patient to ICU for a trial of treatment. You should not be thinking about organ donation at the time of admission, because I think this is where people give themselves a headache and tie themselves in knots with this. Patient gets sick, they're treated on ICU. They either improve, and that's great, or they fail to improve, and a decision to palliate. It's really only that decision to palliate that we should be thinking about a sonography. But at the same time, as soon as they're failing to improve, we should maybe start having that in the back of our mind. So let me take you through a scenario. And I'd say one of our first rules is it's important not to talk about organ donation until the right time. So it's 3 AM, you're a registrar covering ITU. Your bleep goes off and it's the emergency department. This is probably going to be a very familiar story to a lot of you. So it's a 65-year-old with sudden loss of consciousness at home after a headache late in the evening. They go to the emergency department, you go to the emergency department and you find their GCS is 4. Their obs are otherwise stable. So do you intubate and scan? The textbook answer is clearly going to be yes, but if you've got a bit more time, you might want to find out a little bit more info. That's about whether or not this patient's going to benefit from the intensive care. You know, if this patient has advanced early onset sort of end-stage dementia, or known end-stage metastatic cancer, or some other progressive, irreversible advanced disease, then ICU is probably not going to benefit them. But let's say you don't have any history. Well, it's probably time to intubate the patient and get that scan, which you do. Lo and behold, you get this grim picture of an intracranial hemorrhage. Time to have a chat with neurosurgery. So you go through, you get hold of them, they look at the images that you send them, and they turn around and say to you, there's no neurosurgical intervention to be done. Well, now what? So I need to stress that no surgery doesn't mean certain death, and I'll come on to that in a few more slides. Just as surgery doesn't mean certain survival, it's sort of far from it, really. And I worry that people at this point, if neurosurgery has said no, already think about organ donation, and I want to say, please stop that. It's not the time to think about that. That comes much later on. So really, first of all, it's time to pick up the phone and talk to the boss and let them make some of the decisions with the full picture and all the information. So we've got guidance on this. The faculty of intensive care is pretty clear on this. We should be admitting patients with perceived devastating brain injury and supporting them on ICU prognostication, irrespective of any neurosurgical intervention planned or not. The reason for that is we can't predict who's going to do well and who's not, just from their CT and lack of a surgical intervention. We don't know what their outcome is going to be. The neurosurgical reg might say this is non-survivable, but I'm not sure they can really say that. All they can really say is there is nothing that they think would benefit from being operated. We've got evidence for this. So this is published in 2020. This I think group of hospitals developed a brain injury pathway for everyone to come to ITU who had a brain injury, wasn't for a surgical intervention. For over 3 years, they admitted 85 patients to that 85 patients that neurosurgery had said they weren't going to operate on. Of these, 7 survived, and 3 were living independently with some mild cognitive impairment. Now, I'm not advocating that every patient should be taken to ITU, and I think I'd certainly have some serious reservations about the 80 and 90-year-olds that were admitted in this study, obviously depending on their background. The ICS guideline for devastating brain injury states that patients who are intubated will require admission to critical care for this period of observation, unless the extent of comorbidity makes continued organ support no overall benefit, regardless of the extent of a potential neurological recovery. I mean, I take that to read that if they have such poor reserve, such poor comorbidities, that they wouldn't benefit from ITU, then actually they're probably better off being palliated, trying to give them a good death. Just the same as any patient on the ward, being referred to ITU, if they've got multi-comorbidities that are going to mean that treatment we give them is futile, then there's probably no point for them to improve it. It's really important though also to talk about scoring systems. Some of you may have seen this subarachnoid hemorrhage scoring system. It's really important that you recognise that at the bottom of the page there, you can see that it says it's not meant to provide prognostic information. It should not be used as a primary means to predict the outcomes of patients with intracranial hemorrhage. These are really just used for clinical communication and grading, and they shouldn't be used for prognostication. Actually, the author himself has said, it's been extremely disappointing when I hear that physicians have chosen to not treat the patient aggressively or transfer to a high level of care because of a high intracerebral hemorrhage score. So these are tools, but they can't predict some patient's outcome. So back to the case. So, it's 4 AM now. Your patient's had an intracerebral bleed that's not for surgery. As the reg, it's really down to the consultant to make judgments if this patient would like to benefit from ITU support based on their comorbidities. So let's say the consultant follows the guidance and admits the patient, then what? Well, now it's up to you to provide what is, essentially good quality supportive care to prevent further neurological injury. That injury might be from hypotension, dehydration, hyperglycemia, temperature abnormalities, whatever it may be. You need to support that patient, keep them stable so they can prognosticate at 72 hours. That might mean blood pressure support, a central line for NORAD, fluids, lung protective ventilation, and clearly neuroprotection measures. If they get hypotensive, it's important that we treat that. If they get hypertensive, it's important we treat that. And we don't ignore hypoglycemia, so why should we ignore a dangerous blood pressure? So we look after that patient just like anyone else in ITU for 72 hours, giving them good support, and then we see where they are. And again, please note, I've not mentioned organ donation, and neither should you. We still don't know what's going to happen to that patient. It's important that we don't talk about organ donation. We all think it, and we can predict outcomes, but we don't have a crystal ball. I think, hopefully, as I've shown on the previous couple of slides, we don't know who might actually do well. So let's take things forward. If your patient becomes hypertensive, bradycardic, and stops triggering the vent, it'd be entirely reasonable to think this patient's code is potentially brainstem dead. What happens if they become hypotensive? Is that just them dying? Well, we don't know, probably. But if we do nothing, the patient becomes hypotensive and then has a cardiac attack. What if the family turns around to us and asks why we didn't do anything to improve their blood pressure and stop them dying? Until we've done those brainstem tests, we've got no proof of their tone. Are you going to be able to stand in court and tell the coroner that you decided not to treat a low blood pressure? Probably not going to be straightforward. So to protect yourselves, I'd suggest that if you're the reg overnight, support that blood pressure in an effort to get that patient to brainstem tests. The patient's brainstem test confirming death, that's easy, it's a legal definition of death. You can't really question that. So your patient comes in, you support them, you get them through to the morning, they're on a bit of NORAD, pupils are fixed, and they're not triggering the event. Well, time to hand over and let someone else sort things from here. Now it's time to think about brainstem tests. And really it's only now that you should be thinking a little bit about withdrawal treatment and really think about that referral to the specialist nurses. So for someone in this situation, it's about now someone needs to make that referral to the specialist nurse. And this is the process of death by neurological criteria. Death is confirmed by brainstem testing. Ventilation and ICU care continue. Again, the efforts are made to keep that patient stable. And there are very clear ICU guidelines on this, on what to aim for and what medications to use for blood pressure support. Family are approached with the SNODs and with the consultant in charge. Discussion is obviously undertaken and an organisation potentially occurs. The exact order of this can vary a little bit. It's important that the SNODs are present when organ donation is raised. Reason being that they're to support the family and also, you as the person that might be having this difficult conversation. The SNODs are trained in this; they do this on, nearly daily basis. Whereas you're doing it, even in a busy centre, probably a few times a year at best, you're having difficult conversations with the family. And the family ask difficult questions, and questions that come out of left field you can't predict really. And the SNODs are there; they've got the training to help the family with these questions, to come to terms with it, and also to answer those questions. And actually we've got evidence to support their presence makes a difference. Their presence, SNOD presence, has been shown to increase the rate of organ donation. So the discussion's had, and if the family agree, the patient goes on to donate. If someone died by neurological criteria, on average they're able to donate 4 organs. That's potentially 4 lives there that have been saved. The alternative would be if the patient didn't show signs of brainstem death. At 72 hours, it'd be reasonable to assess the patient and review with neurology regarding prognosis and family regarding the wishes of the patient, what condition they accept. If the patient's shown no signs of improvement and the prognosis is poor, then with intention to palliate, again, the organ donation team should be contacted. Just as in a similar manner, if it wasn't a brain injury but another medical problem and the patient's deteriorating despite your best efforts, and the decision has been made to withdraw active support, the referral to organ donation should be made. The first thing I referred a few of our patients with pancreatitis that were dying and certainly liver failure in the past year or so to organ donation. Just the treatment's not working, we're changing to palliation. So the second type of death, when a patient is on ICU, no hope of survival, these plans are made to palliate the patient and withdraw life-sustaining therapies. Just as before, the family is approached with the specialist nurses and discussions had with the patient who wants to donate their organs in the event of their death. And actually, if that's agreed to, the patient goes on to donate, on average, 3 organs are donated. Controlled death after circulatory, donation after circulatory death is then the treatment of organs from patients whose death confirmed using cardiorespiratory criteria follows the planned withdrawal of life-sustaining treatments on ICU. So despite this talk being about organ donation, thinking about donation should actually come really as late in the process of patient care. And unfortunately, it does take time to mobilise the specialist nurses, mobilise the organ retrieval team. So a consideration of donation should come as early as possible at the point of consideration of palliation. The goal of admission to ICU is not usually organ donation, but this comes as this is sometimes an outcome. Patients should undergo maximum medical care. Only when a patient is deteriorating despite that treatment and decisions being made to palliate should a SNOD referral be made. So why do we need organ donation at all? We've got Ecmo, we've got ventricular assist devices, we've got dialysis. Why do we need to go to all this bother with organ donation? It's clearly not straightforward, it's clearly complicated, and clearly a very emotive subject. We know organ donation is tricky, emotional, time consuming. It uses an ICU bed for essentially what may be a dead or dying patient. Wouldn't those ICU resources that are already stretched to their limits be better spent looking after sick patients that have a chance of recovery? If we miss a potential donor, what's the big deal? Donations happen all the time. Well, clearly none of these organ replacements, ECMO, LVADs, RVADs, dialysis, are perfect, and really, they're all there as a bridge to transplantation. To give you a bit of an idea, 70 years ago, dialysis didn't exist. If your kidneys failed, you just died. Full stop, that was it. Diseases we take for granted now are a death sentence. Personally, about a few months ago, I saw a 20-year-old with nephritis. EGFR was about 25 and that was going down, and their kidneys would fail probably in about a year, maybe 2 if they're lucky. And 70 years ago, that would just be the end of their life. But now they're worked up for a kidney transplant, either as a living donation or with a longer waiting list as a deceased donation. What's the big deal? Why can't we just live on dialysis? Well, dialysis is pretty miserable for a whole lot of reasons, but it also affects your length of life, and this graph, I think, hopefully very clearly shows that. If you start this patient in their 20s on dialysis now, just on dialysis, they'll be lucky to live to 35. And dialysis is nowhere near as good as working kidneys. In a kidney transplant lasts on average 15 years. That'll get them to 35 probably when starting on dialysis. And they could have another kidney, another 15 years out of that. That'll get them to 50. Think of all the things we take for granted with kidneys. Think as much food as one, not worrying about potassium in food. It's all taken away on dialysis. Clearly, there are other organs than kidneys, and they're important too. People with ventricular assist devices, it's never going to be as good as a working heart. Clearly, the onus of the heart and lungs or liver is much greater than kidney. So we like slogans, and in ours, organ donation is refer everyone, miss no one. Why are we so keen that no one's missed? Well, as of the 6th of August this year, 2021, there were 5,800 patients waiting for an organ. This is compared to this time last year, where there were 4,200. Most of those need a kidney, but there are 300 needing hearts, 300 lungs, and about 600 needing liver. But there were only about 1,100 donors in the previous year. This was down from about 1,600 pre-COVID. Organ donation has been decimated by COVID. It's a contraindication. There are far fewer potential donors. It's essential that any potential donor gets that opportunity to donate. And this can save multiple lives of patients that are in need of an organ. So who to refer? I'm a big believer in making life simple. So really the simple answer is anyone that's dying in an ICU, refer them. And I'll just repeat that for clarity. If your patient's dying, if you think they might be brainstem dead, pick up that phone and refer them to the SNODs. Don't make your life complicated by contraindications. Don't worry about it. Relax, pick up that phone, speak to the SNOD, and let them decide. I'd say about the only one that is useful to know is COVID. It's clearly a contraindication. If they're dying from COVID, they can't donate. The only reason I mentioned that is because there are so many people dying from COVID. You've got better things to do with your time to do than pick up the phone and speak to a SNOD for them to say no. Everyone else, pick up that phone. As I said before, I've referred about 3 people who were dying in the past 6 months or a year. All were screened out as unsuitable. It takes about 10 minutes. And it could have just as easily been done by a junior rather than myself. But I'd rather pick up that phone and run the risk of missing potential donor. Just save yourself the hassle. Don't be confusing thinking about who can be a donor. Just if they're dying, pick up the phone and refer them. Refer everyone, miss no one. You give that patient a chance to donate. That's going to save others' lives. And ultimately, in ICU, I'm not sure how often we actually get to save lives. We prolong a lot of life, and Unfortunately, we sometimes prolong death in ITU, sometimes not for the better, but organ donation really is a chance to save lives, and often multiple lives. You know, if you refer a patient that donates in one organ, that's one life saved. I did an out program in ICU in Australia in 2012, working in a small, isolated DGH. One day we had a spontaneous subarak who wasn't for neurosurgery. And that consultant on, they were just planning to palliate. But actually the reg in the day, who was an SHO from the UK taking an out program, she asked the question, well, why can't they donate? And they went on to raise some tests and did go on to donate their organs. And she saved lives that day by asking that question, can they donate? So this is really my summary. We can't predict the outcome of brain injury. It's important that we admit patients for prognostication if they're suitable. And it's important that they're supported as we would any other patient. Refer everyone and miss no one. It's important not to talk about organ donation at the time to talk about organ donation. Really, a SNOD should be present for that. And that's at the point where you're thinking about palliation. Okay, thank you. Okay, so that was my talk. Hopefully that came through all right to everyone. Does anyone have any questions they want to ask about that? So I think we've got the Royal, I think hopefully they've joined in with Martin, but so I think for everybody really just to, summary of all that really is that overall kind of organ donation numbers are right down with COVID. The waiting list for transplant, any type of transplant, has massively increased over the past year and a half with that. I think the organ donation nurse is going to talk a little bit more about the importance of missing no one, but it is really important that those patients that are in a position to potentially donate, we do think about it. We don't miss any potential donors, and it's also important that these patients are admitted not for organ donation. That's not kind of the primary goal, but they are admitted for prognostication because we don't know their outcomes really. Any other questions? Otherwise, I'll hand over to SNODs. Liz, if you want to get yourselves ready. Any questions from?
Oh my God, I'm being rebooted.
Ricky?
Yes,
Alex here. Just one quick question. How you doing? You all right?
You in the car?
I'm in the car on the way down to my sister-in-law's.
Hello, Keishan family.
Dedication to education.
Very good.
Thanks for the presentation. I agree. I think there's a sea change in the last sort of 10 years in admitting patients, and we try our hardest at the Royal. Things have changed a bit with COVID and availability of beds and things, but just one question really is, with the change in law, have you noticed any difference in organ donation rates at the moment, or any or even just the approach to the families? Has that been significantly different?
So I'll hand that over to the SNODs. I think we haven't really seen we haven't got the evidence for kind of a massive change or any sort of massive changes in the UK yet. Obviously, it's, our numbers have kind of been massively skewed by COVID. It's not going to make that sort of pulling the detail out a bit easy with COVID that's happened. Liz or Steph, do you want to make it? In terms of that, how does that affect your conversation with family?
So it's a very commonly asked question, that, Alex, and unfortunately we can't give you a straight answer because it's not the same as knowing if they would have said beforehand yes or no. Because we're doing a presumed deemed approach, the approach to the family stays the same, but actually unless we do a feedback system where we say, would you have said yes pre-law, had this not been the case, we won't ever really know that information of actual numbers as to how it's been affected. So there is no data at the moment for that, and obviously you can understand that we can't really go back to families and ask that information.
Do you find the families are more aware of the rule change? Do you think the education of the population has been good, or is it still a big shock when talking to them about organ donation?
I think that the amount of actual advertising that we were doing through COVID, we had got a lot of planned TV and radio time, and that all got taken up with COVID messages instead. So we lost an awful lot of our opt-out promo that we had actually planned to do. And unfortunately, because of the time that it was going through Parliament, the delay would have been 2 years plus had we had to delay to that point, because it would have gone on back to the bottom of the queue for discussions in Parliament. So it was a decision made that we did have to go through. Again, we've picked up the promotion side again. Has everybody heard about it? Probably not. And it's something that, you know, it's quite difficult to know with regards to consent and what have you. But we are, because we ask the families in the same way, and we say, you know, what would that person have wanted to do? Although we say we presume they have no objection, if they can give us an opportunity, a time when they've said yes or no, we take that as their last known decision. So it's not just we're deeming you, that's it, the end of it, you know.
The choice remains the same.
Yeah.
We are finding that families do know about the law, and are sort of, you know, bringing that up as well when you're in those conversations.
And just one final question: did you, before this law came out, did you have training to change your approach to family? And if so, how did that change?
We had we did have training on the law, and it was based with how the law had been changed in Wales, and the positives and negatives of what they found, of how that had gone. With regards to what we're asked to say, I mean, I know you've had the talks at the RCS and things of different phrasing and things to say, but apart from really we presume that they would have no objection, the way we ask families is exactly the same, the way we approach them is exactly the same, and it's sometimes not to the point until you get to the consent form and you're doing all of the questions that you actually work out if this person could actually be deemed or not, because they have to fit certain criteria. You have to ask quite specific questions in that, and so it's because of where we actually put them with the consent form, we do a lot of questions first before we do the actual consent now, to get that information out, to work out which part of the consent form we sign. But making sense.
Yeah.
Sorry.
Brilliant. Thank you very much.
Okay, just start off by introducing the UHL organ and tissue donation team. Ricky, you've obviously met, the clinical lead for organ donation. And it's probably a good time to introduce our new clod as well, which is Cindy Horst, who I believe is on the call as well. Welcome, Cindy. And then I'll just talk about the two specialist nurses. So they've split the SNOD role into two. So you've got myself and Steph, who are here today, and they've introduced a new role called an SR role, a specialist requester. The ones at UHL are Rebecca Ashman and Danielle Smith. And the reason that they've split the role is that we were only approaching and consenting families really infrequently, so we weren't that great at it. So the specialist requester role is purely to approach and consent families. During the presentation, I'll just refer to the term SNOD though, and that will cover both roles just to make it easier. So sometimes you might knock on our door in the morning and ask for us to attend family conversations, and we might ask you for a delay, and that is because the gold standard is for a specialist requester, the people who consent and approach families every day, to be in that conversation. We can be in that conversation and approach those families, but ideally it'd be somebody who's more qualified. and that's sometimes why you might find that there's a different person to the person you asked to attend the conversation, or why we ask for a delay.
Okay, so a big part of our role as embedded SNODs is to do the potential donor audit. So we audit every death in ITU, PICUs, and we're just bringing in the neonatal audits too at the moment. And so we just want to know how many actual donors there are compared to how many organ transplants we do, and how many donors referred and things. So this is a UK-wide data, and we've basically kept the data from 2019 to 2020 because COVID was so prominent in 2021, and this is a more accurate data pool of the last few years. So in the UK there's about 620,000 deaths a year. In the hospitals it's 280. Of those potential donors, so that's donors in an ITU, PICU, that are on a ventilator that have been withdrawn on, there's about 7,400 a year, and of those, the ones that were referred to the donation team were 6,000, almost 900 of those. 3,200 requested donation, and we consented 2,300 of the 6,898. But only 1,500 of those actually went on to become donors. So from consenting a family to actually going to theatre, things can happen in that time. So patients can go into terminal decline, and we obviously have respect forms in place. We won't do anything dramatic, just for the facilitation of donation. Or we might find that something in their history has actually contraindicated them to be a donor. So there's lots of different reasons, but for that year we had 1,580 actual donors, and going to the bottom, they transplanted 4,140 organs into 3,760 people. So some people have a double transplant, so heart and lungs, or pancreas and kidney is quite often as well.
So I'm just going to talk through the NICE guidelines. So CG 135 is in relation to organ donation, improving donor identification and consent rates for deceased organ donations. I'm not going to bore you too much with all the details, but we've just pulled out a few key points. So identifying patients who are potential donors. Point 1 is to just ensure that organ donation is considered as a usual part of end of life planning. Point 2 is to identify all patients who are potentially suitable donors as early as possible, either through being a catastrophic brain injury with the absence of one or more cranial nerve reflexes, or a GCS less than 4, or you're planning to withdraw treatment. In terms of approach, the NICE guidelines suggest that it should be a multidisciplinary team being responsible for the planning of that approach, that being doctors, nurses, the SNODs, and any faith representatives that families should request. Before approaching, it's important to identify whether the patient is actually a potential donor. We've had some approaches, especially sort of in paediatrics really, where families have been approached by perhaps a nurse, and then it transpires that that baby isn't suitable, or that donor is not suitable. So it's really important to make sure you have a conversation with us beforehand, just to make sure that we don't cause families unnecessary stress in that already difficult situation. We can also check if they're on the organ donation register before approaching to see whether they've opted out, and it's important just to consider whether the coroner would support organ donation before you discuss it with families, and whether there's any legal or safeguarding issues. Other points that are not on the NICE guidelines would be, best practice would be for it to be a consultant only approach, with a SNOD obviously, unless the family bring it up first, or unless you've had a discussion with the consultant and plan to approach a family. And introductions always seems to be sort of a bit of a tricky area. What do you introduce the organ donation nurse as to the family, especially when you're involving us in early conversations? It can be quite difficult for the medical team and for ourselves, really. Some people feel that we're not being necessarily open and honest with families when we don't introduce ourselves as an organ donation nurse. But because at that time families haven't been told about futility or haven't accepted futility, we tend to just introduce ourselves as specialist nurses. And this brings us on to what's called the decoupling approach. So this is the gold standard of how you approach families for organ donation. So you have your first conversation, which is your futility conversation. Point 20 is to make sure that they understand that death is inevitable or has occurred. Often in this first conversation, you can get families asking you about next steps, and it is important at this point to try and allow sufficient time for that loved one just to absorb the information that somebody is going to die. So we always try and recommend a bit of a pause before you go on to the second conversation. And this is the decoupling. So the second conversation will be when you go in and have your end of life options. And we prefer consultants to stay in this conversation because it does affect the consent rates. Families are more likely to consent with a doctor there, and it shows that multidisciplinary approach. But equally, we appreciate that you're busy, and sometimes it's just easier for us to take over that conversation. And point 24 highlights that in the NICE guidelines. Discuss withdrawal of treatment and neurological death before and at a different time from discussing organ donation. One point to think about with approaching consent is often we go into conversations and families are literally ready for us to take out the tube. People think that's what we've gone in to do. So sometimes if we're not involved in those early conversations, it's helpful if families are not set up to the point that they're planning to withdraw, because then it makes it really difficult for us to sort of introduce organ donation and then having to get families to think about a further 24 to 48 hours of ventilation. Sometimes they haven't really got the headspace for that. So that's why it's really good for us to be involved in those early conversations.
If we're trying to pause, and actually you want that pause between the first and second conversations, something just as easy as saying, you know, I've given you a lot of information, I want you to have a little break just to think about that, let me get you a cup of tea, have a few minutes, and then we'll reconvene and talk about next steps. You know, it can just be a simple phrase of that, just to decouple that, and just stop that family grabbing at every bit of information they can have at that time, really.
Okay, so that's the NICE guidelines.
So Max and Kira's law. Okay, so there's very strict criteria in actually deeming somebody. So they need to have no known decision. So that might be on the organ donor register, but we also ask families as well, have they ever expressed a decision? Have they watched something that they watched Hobby City and said, no, I don't want to do that, or do want to do that? Any kind of conversation that they've had. So they need to have no known decision. They need to be of age, so above 18 years old. No mental capacity concerns. So that's not just little mental capacity things. It's quite severe dementia, severe other, I can't think of any right now, but you know, the ones that they wouldn't actually be able to understand the law. They need to be of ordinary resident, which basically means that if they're placed here with the military at a certain base, some religious leaders are placed in a certain church, things like that, then they're not considered to be suitable for deemed approach or deemed consent. They have to live here voluntarily, and they have to have been living here for 12 months. Okay, so we do have a lot of jobs to get done when we're assessing a patient, characterising a patient. And this is the longest part of our job, organising echoes, chest x-rays, bloods, different things like that. So for us to be as less problematic to you guys, if you could give us a doctor for half an hour. It could be a junior doctor, you know, and we can just give them a list of jobs to do that we can try and facilitate during working hours. That would be really useful in actually sorting out, maintaining the donor, get DDAVP prescribed, vasopressin prescribed, things like that, you know, and actually then it takes the pressure off you guys as senior doctors to actually, in knowing that all of the boxes are ticked for us. And we will bother you a lot less, I promise, if that happens. We obviously need to go through timings with you guys, what your expectations are of actually when theatre will probably take place. The location of doing a DCD withdrawal will either be on the unit or in the anaesthetic room, sometimes in recovery as well. And actually what you guys are comfortable with, and that does depend on the time of day and how far away you are from theatres, but everything's a bit of a discussion with that. There are other things with regards to donor management with DCD, so sometimes they do need central lines and things like that, which is a really delicate subject because you know, we've got this ethical dilemma as to what we should be doing for these patients, and we should be treating them with the dignity and respect they deserve, but also helping them to do, if they had actually wanted to do this, to actually honour that decision as well, and helping them to live with that as well. So it's all a little discussion that we'll probably have with you, and it's really good for you to be open and honest with us about what your expectations are of how far you're willing to go, you know, what inotropes you're willing to start or go up to, and just looking at management of fluids and things. Respect form, obviously we would need that in place, and then looking at kind of non-symptomatic treatments would stop some, but things like antibiotics and things would ask those for those to be considered, to be carried on, because those organs are going into somebody else and those potential infections will continue on. So we would really appreciate things like that. So just going through the drug chart and actually carefully ticking off what's needed, and you know, keeping on the bits that, you know, just thinking about carefully. End of life symptom relief, again, that's your choice with what you want to do with that. We don't have a say in that, but it's again just good communication with us, just so we know what the plan is. And then documenting the plan. So the theatre, the transplant team will need to see documented the plan of care. So in a DCD, they have to have, the plan is for withdrawal of treatment, plus or minus organ donation, depending on if they do proceed. Including in that will be extubation, termination of inotropes, and comfort measures, something like that. And to be signed by a doctor. And it seems a really silly thing to have to write, but to try and to get that written is actually one of our hardest things to do. And it's so important that the theatre team have to be able to see that before we go ahead with donation. And also for us, a 1A, 1B, 1C and a 2 in the medical notes is always really useful, because we're not doctors and we really do appreciate that as well, if that's possible, because all of the patients will be discussed with the ME prior to donation anyways, so hopefully that will have been provisionally agreed already. So if you could just document that too, that would be brilliant for us. So immediately prior to withdrawal, things to consider for you guys. Plans for transfer. So if we are withdrawing in the anaesthetic room or recovery, we'd need a doctor that can do airway management to take us round. If we're doing withdrawal on the ITU, we'd need a doctor to be able to certify a patient has died. this has to be at the moment a doctor, it can't be an ACP, and that it probably will change at some point, but for now it has to be a registered doctor with GMC. Obviously we'd need the arterial line to be working. Things to stop is all essential, all non-essential infusions, and any renal replacement therapy. Ecmo is an interesting one to consider. We've just done a withdrawal off Ecmo on a paediatric patient in the last month, and that was really well done actually. It was supported by Chris Harvey, who looked at all the Ecmo cannulas. He actually came into theatres and scrubbed to remove the cannulas out of the way, so the theatre team could retrieve the organs as quickly as possible. And it just needs another kind of thinking about, but it's something that we'll need to, obviously, that will affect where we're going to withdraw, how quickly they're going to die, usually. And then any equipment that you'll need for certification. So when we ask for a doctor, the time we wait from withdrawal to asystole is usually up to 3 hours, and we'd need somebody brief doctor-wise for most of that time, which it's quite difficult for you guys being so understaffed to actually be able to facilitate that as well. And again, that might affect where we actually withdraw and what we do. So it might be that you hang around for the first half hour, and if the patient stabilises, then, you know, as long as we can contact you, it might be, you know, again, just a discussional thing at the time as to what actually you guys can offer us and what we can utilise. But having equipment as well, you know, you're going to need a stethoscope, you're going to need some gauze to do your eye test, you're going to need a torch to check your pupils, just things like that. It's just making sure that you're prepared for that. And then during withdrawal, so if I'll use an example of going round to the anaesthetic room because it's easier to talk about, but it's essentially the same as ITU. So we'd need a bedside nurse to go round to care for the patient, and we'd need a trained doctor in anaesthetic, well, tube trained. Once everybody's round there, the theatre team will probably just do a quick huddle with the doctor, just to go through their expectations of what's involved, and that the doctor's happy and that they don't have any questions. When everybody's ready, at a certain time, we will extubate and stop the inotropes, and then we will do a lot of timings after that and just watching very carefully the observations. So we're looking at the ECG and the SATs and the arterial line blood pressure, and as they drop, we'll be passing the numbers through to the theatre team so they know what's happening with the warm ischemic time, and to make sure that they can be prepared and ready. This is all the part of the SNOD, and this is what we'll do in the background. And then once we're going to use asystole on the arterial line, because you can have some PEA rhythm on the ECG when you don't have actual outflow from the arterial line. So once we're happy that that actual flow has gone and there's no pulsatile trace, we'll kind of nod, the doctor and the SNOD will kind of nod to each other, and they're happy to start the clock. And at that point we give 5 minutes, and where we do a complete standoff time for 5 minutes. So we would expect the doctor to be watching the monitor, looking at the ECG, looking at the arterial line, and then listening as well with the stethoscope to make sure that they have full cardiorespiratory arrest for 5 minutes. In those 5 minutes, we don't really do anything else. The family will leave during those 5 minutes if the family are there at that time, but that will be the SNOD and the bedside nurse looking after them. So we just really want you to focus on the patient at that point and making sure that certification of death is absolute, and that you're not worrying at any point. If you need further time, then you can have longer. we say 5 minutes, it has to be 5 minutes, but if you do need to carry on a little bit, there'll be no forcing you to go quicker. It will be, are you happy? Yes, I'm happy. No, I'm not. Give me a bit more time. You know, it's as long as there's good communication between the specialist nurse and the doctor, then that's absolutely fine. And then once you're happy that we've had 5 minutes of circulatory death, cardiorespiratory arrest, then it's supraorbital pressure, pupil reaction, and corneal reflex. And if you're happy with those, then you can say, yes, I'm happy that that patient's died. Then what we do is at that point, we have to work quite quickly because we've now got this warm ischemic time. The nurse and the bedside nurse, the specialist nurse, sorry, and the bedside nurse will start removing all the lines off the patient. The gown will probably be underneath the armpits, so it's ready just to pull down in theatre rather than having it above the arm, over the arms. We'll lower the bed quite quickly, take the pillows out, make sure it's height of the theatre table, and then it's a very quick transfer into theatre, pat slide across, check the wristband, and the theatre team will get straight on with the surgery. And then we stop, and you have this sometimes sense of, okay, what have I just done? What have I been involved with? That's happened really, really, really quickly. Everything's just gone from 0 to 1,000, and now I've stopped again. And now they're doing surgery, and this person was fine, and this person's now not fine, and this person has died. And it can be very overwhelming sometimes, especially the first time you actually experience it. The theory versus the practical situation can be very, very different and very, very emotional, especially as an ITU doctor when you have actually been treating this person for a few days or weeks and you've been wanting this person to get better, and suddenly this person's not getting better, and actually we're doing something completely different that isn't beneficial for this patient right now because this patient has died. And that can really, really play on heartstrings and emotions. And I would always say that to expect feeling not okay when you get to that point because of how quick it is. And we do this a lot, and it still affects us as specialist nurses each time we do this with a patient. You know, there's no positive end for this patient. There is a positive end for somebody, but it's not for this patient, and that is really, really hard. And what I would say is please try and speak to us afterwards if you're feeling quite challenged by this, because it is, until you've done it, you don't understand the emotion that you feel actually at that point. The last thing that you will need to do is just to confirm to the theatre team that you have actually certified this patient. So we've got a specific form that we have, and it's just basically everything that I've just said: the eyes, the supraorbital pressure, the cardiorespiratory arrest, and you just tick it off afterwards. But you don't have time to do it in that moment. So once the patient's in theatre, then we'll sit and do the paperwork afterwards. But a verbal confirmation of death is all that they need to be able to start theatre. Does anybody have any questions with that little bit? Because I feel like I've just talked for quite a while on that. Okay.
So we'll just go through DBD, which is luckily a lot more straightforward. So you're going to be starting with your neurological death testing, which will be performed by two doctors, two sets of tests. So there's two forms. There's a long version or a short version. It doesn't matter which one you use. Doesn't matter how long between the two tests you wait. Then you get to the point where you're optimizing your patient. And I'll talk a little bit about the DBD care bundle on the next slide. There's something also you need to be aware of, which is the Signet trial, which is giving simvastatin to donors. So it might be that you're asked to get involved in that, and you've probably already heard about this already, but you might be asked to prescribe that. Okay, then off to theatre, which is easy. It's your normal transfer, your normal anaesthetic to theatre. And then once you get to cross clamp, then your work here is done. And so it's a lot more straightforward for you. After cross clamp, you do your normal documentation for your trust. This is the DVD care bundle. There is a DCD care bundle which is being formulated, which is probably quite similar, to be fair, just a few different things, but that's not come out yet. The care bundle is pretty much the same as your ITU care bundle. There's just a few differences. So one being that after neurological death testing, you should be giving a dose of methylprednisolone. And again, after 12 hours, if you're still waiting for your retrieval to take place, and you've got the dose on there. This will reduce the cytokine release both before retrieval and during surgery. Giving DDAVP as well for your diabetes insipidus is also something on the care bundle. 65 to 90% of neurologically dead patients, the sort of pituitary gland will be damaged owing to a lack of antidiuretic hormones. So you'll get your polyuria, your hypovolemia, and your hypernatremia. So it's important to keep these patients stable when desmopressin comes in. And in terms of inotropes, vasopressin is the gold standard for organ donation, plays a central role in stabilisation of neurologically dead patients. The evidence shows vaso is associated with sort of an increased rate of organ recovery and maintains lung function. I'll just bring this up. So briefly about tissue donation, very briefly. It's another reason why you should refer all and miss none, because those patients that we know are contraindicated for organ donation, we pick up for tissue donation. We're 20 people down every month for corneal donation at the moment. So there's people every day that can't see the faces of their children. We're missing those patients because you're not referring them. So if you could refer them, we could pick them up for tissue donation. Many of them have opted in for this as well, and we'll just be good to catch them. Finally, sort of echoing what Ricky said, really, to refer all. So any end-of-life patient, if they're self-ventilating, consider them for tissue donation. If they're vented, consider them for organ donation. Knock on the office in office hours and we can pick up these referrals. Otherwise, there's a 24-hour numbers. If you're at the Royal today, I've put some of these laminates in the doctor's room there, and I'll drop some to the other sites next week, so you'll be able to pick those up. So you've got those numbers, and you know you can ring 24/7. Before we get to that, there's one slide that's not on there that Steph just wants to briefly talk about, which was the bereavement support element of our role.
Yeah, so I don't know if you guys are aware, there's two charities that offer sibling support for you as professionals to talk to the siblings or the children of any bereavement end-of-life patient. So Rainbows, they will take any referral of a patient up to 25, and they will come and support the family. They've got a couple of specialist nurses on site in UHL at the moment. And they are really, really good at actually doing sibling support and explaining things in a really nice way. And anybody 25 and under can actually be transferred to Rainbows to the cold rooms post-death or for withdrawal, if that is appropriate for the family. And then the family can spend days or weeks there with their child or with their partner in that space. And then if for anybody over 25, the Laura Centre, they have a phone call system. So if you have some siblings or some children, and you can call them up and say, I have a 6-year-old that we're in this situation. How am I supposed to tell this child that their mum has died or something like that? And they will actually coach you through it, and they will give you that support. So I'm going to be doing some work on this and doing some more information sharing with this over the coming weeks and months, but just as a start off, just so you are aware of some of the services that they have in UHL that can support you. And we're done. Thank you.
Questions?
Sorry, we were a little bit longer than we should have been.
No, that's brilliant. Thank you. I think certainly made some things clear. We've got a question in the group. So Snods, I'm going to hand this one over to you. Say, for example, a COVID patient is moved to the clean area, as seen as non-infective greater than 21 days after a positive COVID test. Would they be suitable for donation at that point?
Yeah, so it's actually 28 days after a positive test. Anyone above 28 days can be considered as a donor. And we do have a lot of patients that are actually on COVID positive units because they don't have a negative area. As long as that patient has been brought up ventilated and has gone into a side room and they are seen as being acceptable for referral because they've been protected through the COVID positive unit on a ventilator and then protected throughout in the side room, then that's absolutely considered as a donor, and we have done them.
So that's, you say 28 days after admission or after?
Yeah, I think recovery.
But it depends really on how they're being affected at that point as well. If they're home, then they're still sort of on quite a lot of support at that point. They're still down. You would, yeah, it would be.
But still worth referring to let yourselves make a decision.
Absolutely, yeah. That's true, over 28 days.
Cool. Any other questions? Yeah, Alex, or Alex and Jenny. Alex, you go first. Yeah.
Thanks. Just a request, really, more than a question. I know you've got the national potential audit donor audit. I was just wondering, we never get really. Obviously, you show us cases or send us cases which could be perceived as missed opportunity, but we never get actually the full data for our hospital, and it would be quite good to have that on a quarterly basis so we can, just map how we're doing and try and improve, put processes in place to improve things. Is that data available?
Yeah, we can organise that, Alex.
So we did organise that actually last month with Mike Little, because when we did that M&M meeting, we actually went back to him afterwards and said we do actually want to feedback positive data to you guys and not just the one missed in 1,000 others. We want to celebrate your achievements as well. So the plan has been to put it into that meeting as well, if that's okay with you, unless you want to.
Absolutely.
We can feedback.
No, absolutely. That's the perfect place to bring it to. So yeah, thank you very much.
Okay.
Cool. Jenny, you got a question?
Yeah, sorry. Thanks, Steph, for what you were saying about support of siblings and younger children. Could you just say how we access that support again? And also from a personal point of view, patient that we both know, just telling everybody how special the experience is at Rainbows and how it really helps the family and the siblings grieve more effectively and move on with their lives afterwards. I think if we can do that for suitable cases, that'd be amazing.
Yeah, no, absolutely. The Laura Centre has a phone number that you can call in off hours, which I don't have to hand, but I can share that afterwards. And then the Rainbows, they actually have got 2 specialist nurses that spend in their time split between Rainbows and UHL, and they have a consultant paediatrician as well. That again, she splits her time between UHL and Rainbows as well. But they are based more in UHL now, so it would be a phone call to them, which again I can supply numbers for them as well. But they live in the Kensington, the Jarvis building offices. You know the offices where Comet is and Centre. I don't know if you know. They live up there, so they're very close to hand. They're happy to do the Glenfield or the Royal or them as well. Anybody under 25, they will.
Yeah, we've got some links and things to share. So if I add them to the links and then send them to Ricky, we can distribute.
Yeah. Cool.
Okay, lovely. Thank you.
So the journal article I'm presenting is the effect of the consent rate for deceased organ donation in Wales after they changed into the opt-out system. So obviously this is covering a lot of what we've already discussed, but in the UK, across the 4 devolved nations, they each take responsibility for their own healthcare although organ donation is looked after by a single UK-wide service in NHS Blood and Transplant. There are two major categories of legal framework, which we've already discussed, being opt-in and opt-out systems. And this was looking at the change in Wales compared to England after Wales introduced their opt-out system in December 2015, before England and Scotland had made any changes to their legislation. Obviously, we've already discussed this, but opt-in is when there's been express consent from the patient or their relatives, be it written or verbal historically, whereas the opt-out is consent is presumed in the absence of a statement made by the patient in their lifetime to the contrary, although family are still asked their wishes in this. So the methods for this, it was a prospective comparison of consent rates for deceased donation in Wales versus England. Scotland was excluded because they'd publicly announced at that point the plans to explore the opt-out system, so they thought that that might skew the data, and Northern Ireland's numbers were considered too small to really impact. The data was taken from the UK Potential Donor Audit, which is a continuous national audit of patients 80 years or less who die within an intensive care unit or an emergency department in the UK. They calculated the consent rate, so that was the proportion of families of eligible donors who were approached for formal organ donation discussion, where consent for donation was given. In 2015, because of the changes to legislation in Wales, the UK Organ Donor Register slightly changed their information to allow expression of either opt-in or opt-out. So they tried to avoid bias by individuals who had already opted out on the organ donation register were still included in the consent rate calculation, even if the families were only approached to inform them that an opt-out decision was already registered. This was because the awareness of opt-out option was obviously much higher in Wales at this point because of the government awareness campaign that had been running for 2 years prior to the change in system. The data that they used was extracted from the UK Transplant Registry, which records all donors and transplants, and they did separate analysis of donation following circulatory death versus donation following brain death, and they also calculated some baseline consent rates prior to the change in opt-out system. So they used something called a two-sided sequential procedure to analyse the data. It was designed to have a 90% power to detect an absolute difference in the consent rates between England and Wales of 10%, with significant 5% difference. The reason they chose to use this type of study is because it meant that they could regularly review the data looking for significance, which they did quarterly rather than waiting for several years before they were able to fully analyse the data. So they used cumulative consent rates, and as I say, they were compared quarterly to review those results. So they estimated the sample size they expected and deemed a duration of 3 years should be acceptable. And they were expecting that in England there would be approximately 20 times the eligible donors that they would find in Wales, the population of Wales. Following this analysis, they did some retrospective risk adjustment analysis, specifically looking for other factors that are known to affect rates of organ donation, such as evidence of the patient's prior decision, their ethnicity, any pre-mention of donation, and if a specialist nurse for organ donation was involved at any point. They then used the data they got to do a quarterly evaluation of the significance of the difference in the cumulative proportions, comparing percentage consent rates essentially in the two groups and the difference in those. So between the 1st of January 2016 and the 31st of December 2018, in England, 8,192 patients' families were approached with a consent rate of 65%. In Wales, it was 474, with a similar consent rate of 68%. The baseline consent rates prior to the change in legislation for DCD was 53% and DBD was 67%. So this was the breakdown of their results quarterly, again separated into donation after brain death and donation after circulatory death. So in Wales, there was quite a lot of variation in the quarterly rates, which was presumed to be just likely secondary to quite a low number of donors compared to England. However, the quarterly donation after brain death consent rates in Wales were generally higher than those in England, as you can see in the quarterly breakdowns for DBD. For donation after circulatory death, the rates in Wales were actually initially much lower, so 44% consent rate compared to 63.9 in England at the start, and they gradually increased and actually overtook the rates in England. So at the end, in the final quarter, the consent rate for DCD was 76.5% in Wales versus 62 in England. The data that they got, they use what we call a Z statistic. So this is basically they compared the quarterly evaluation of the significance of the difference in consent rates, and then they plotted it against the number of eligible donors whose family were approached. But basically these graphs show that the small circles in the middle are the quarterly Z statistics, which compared the consent rates. The blue boundary lines, so if the dots cross the blue boundary lines, then that's deemed to be significant. If they don't and they cross the dotted line at the end of the period, then it's deemed that there was no significant difference. So as you can see in the upper one for DBD donors, there is a statistical significance to the Welsh consent rate being greater than the English consent rate. So this was the unadjusted analysis. This was before they'd altered it for any of the variables. There was a statistically significant increase in the DBD consent rate in Wales compared to England, but there was no evidence of statistical change in the DCD consent rate in Wales relative to England. And they then did some regression analysis, adjusting for how the type of donation influenced the likelihood of consent and taking into account the other factors that we'd already discussed as reasons that people may or may not donate. They looked at the effect of the donation nation, so England or Wales, and the year of donation to account for changes over time, and they got much more meaningful data out of this. So they combined for this DCD and DBD, and over time it became highly significant, showing in the first year the chance of consent was significantly lower in Wales. In the second year, it was equally likely that somebody would consent, or family would consent in England or Wales. And in the third year, the chance of consent in Wales was double that of England. Having said that, a higher proportion of Welsh patients had shown a prior decision to be an organ donor, 40% in Wales versus 33% in England. In those without a prior donation decision, either on the organ donor register or verbally, the chance of consent was almost 3 times higher in Wales, where obviously the opt-out system was in place versus the opt-in. system in England. Both English and Welsh donor numbers increased during the period of observation. So this study was a prospective study. Others had been done, but they were mostly retrospective, and the comparison was made usually with similar jurisdictions, but not necessarily the same jurisdiction. Occasionally they were before and after, but they felt that the prospective nature of this study made it different and improved. They did, however, assume that the underlying consent rates for DBD and DCD in England and Wales were the same prior to the change, as were almost the same population, although they didn't have any evidence to suggest that they were entirely the same. They also assumed that there would be an immediate impact from the change of legislation, whereas actually they didn't really see any significant changes in consent rate until about 2 years following the legislation change, and had it been assessed for maybe another year or so, they may have got more data from that. Scotland and Northern Ireland were excluded, but they felt because of the small numbers they were likely to include that they probably wouldn't have made a significant difference statistically. The real question is whether this is evidence of the legislation making a difference, or whether it's just a greater discussion and awareness of organ donation. In the 2 years prior to the legislation change, the Welsh Government spent £2 million with a media promotion campaign within Wales, getting a 74% awareness in the population of the changes to legislation before the implementation. So the query is, was it the change of legislation or was it the public awareness which actually made a difference? Now we've changed, with the changes in legislation in Scotland and England, we may be able to get some more information on that at this point. And that's it.
Thank you, Heather. That's not a straightforward paper to go
It's a
through.
nightmare.
Certainly one of the things that was raised is that Spain kind of leading the way for organ donation, certainly across Europe, and I think possibly the whole world actually. It's always asked what's Spain doing that's different that are making them so effective, and they have an opt-out system that is certainly raised as one of the reasons why they have so much success with organ donation really. I think this paper kind of seems to show that certainly early so far, and I think there's data coming out in the UK, it might be making a difference from the, sorry, there's certainly data for Wales sort of actually presented seemingly showing that an opt-out system is making a difference. Obviously the data in the UK is not going to be straightforward, in England is not going to be straightforward to get because of COVID kind of completely messed up those numbers for the past couple of years. But yeah, that sort of, it's a complicated paper, lots of stats in it, but it certainly seems to suggest that opt-out or sort of deep consent does seem to make a difference. Are there any comments from anyone?
Ricky, in Spain, do they give the family the opportunity to overrule the consent? Is their system the same in terms of opt-out, or do they have that safeguard? Or once you've opted out, no one can bar it? What's the system there?
That's a good question. I'm not entirely sure. I know they have an opt-out. I don't know if it's kind of we talk about sort of a soft opt-out. I think again the SNODs will be able to correct me on this, whereby if a family member has clearly opted out on the organ donation register, that's them out. They've said no, they don't want it. If they've not made their wishes known, the family can still override. I think that's correct, Liz. If that's, can you help me out on that one?
Yeah, we're not entirely sure, to be honest. Not sure about Spain.
Yeah, not sure about Spain actually. We'll have a look at that one, Rob, and get back to you. Yeah, it's an interesting point actually.
I mean, I'd be a bit peeved if my family overrode my wishes, if I'm really honest. But
yeah. I mean,
I think
that's what,
sometimes though it's not necessarily as straightforward as that. I used to think that when I first came into the role, and I think when you're sitting down with that loved one and the sort of practicalities and the logistics of organ donation, you know, they're expecting it to be the end of that person's life, maybe that evening, and then we're asking them to consider, you know, ventilating that person for the 24 to 48 hours and undertaking various tests, maybe lines. There's a different side to that, and I think sometimes, although like you say, you might be peeved with it, when they sort of, your loved one sat there for weeks on end at the side of your ITU bed, and then that might just be a step too far for them in terms of emotions.
Yeah, that's a very valid comment, and also you're not really in a position to be peeved because you're not there, are you? But yeah, but yeah, no, I'd just be really interesting to know what's different in Spain, because I can't see that somehow their population would have such a different cultural view of it to us.
A lot of the Spanish nurses that we've spoken to, and that they actually wanted to discuss the law change and things, they were actually really surprised that the families, you know, would even consider overriding the decision or choosing to say no, because very much in their Spanish culture it is just accepted that that's what happens.
That's interesting.
Just a different cultural view on it, I think.
And I think the other thing to think about with consent on the ODR is that although it's registering a decision, it's a difficult one, because anybody can register for anybody really. You know, children can register themselves, but also adults can register different people. So you have to be very careful in how you take that ODR registration as well. I think,
did that person understand the process when they ticked a little box on their Boots card? Did they realise the extent of what that would entail? That's some of the things, that questions that we had to sort of delve into with families.
I mean, there was another situation where there was two patients next to each other in an ITU, and one was a couple of days ahead of the other one, and the family next to them watched them offer donation, what have you, and actually went on to the ODR, opted out for that patient. And then a couple of days later, when we looked at the ODR for that patient and realised they'd opted out whilst being ventilated in an ITU bed, and actually it was the family, you know, actually that family were really concerned that we were going to approach donation and wanted to make sure it didn't happen, which is fine. But obviously, you know, they're registering that decision for that person, you know, and again, it's just that family dynamics, actually being in that room early, knowing what they would want and working with them, because we don't want to create a barrier between them and you offering something that isn't appropriate, but having that knowledge as well, you know, of their expectations, just help.
Jenny, you got a question?
Yeah, so it was really interesting to hear the sort of levels of awareness amongst the Welsh population about the change in legislation about organ donation as a concept. Obviously, the sort of numbers of donors in the UK have been completely mangled by COVID, but is there a plan to survey the population in a similar way to gauge levels of understanding and knowledge? It seemed like the main difference, they've obviously not had the advertising campaign because it.
I haven't heard of any. I imagine there will be. I haven't heard of any official one that's going to happen so far, but I can let you know if it does. I imagine there will be though.
I think sort of one of the big things about the kind of opt-out sort of change in law was actually this was going to bring a hell of a lot of publicity to organ donation, and I think in many ways it was more about, you know, this was going to be talked about, this was going to be in newspapers, this was going to be on TV, radio. It was just going to put it out there and raise awareness of it and get people talking about it. And then I think it was due to happen, I think about May last year, where obviously we're just in massive, you know, COVID disaster zone everywhere, and that's all it was. So COVID has very much caused, well, obviously problems everywhere in every department, but it completely overrode the kind of publicity we were hoping to get from the change in law. Any other last questions? Otherwise, I think probably draw it to a close there. Anyone else? Otherwise, I think we'll probably call it a day. Thank you very much, everyone. I hope that's been useful. Obviously, if there's any questions or anything that you think of afterwards, you know, feel free to just drop us an email. Whatever, I'm happy to be approached, really. Otherwise, we'll draw it to a close there. All right, thanks everybody.